All right, so now we'll talk about the intercostal nerve. So here what we have is a diagram showing us that the intercostal nerve is a branch from the spinal nerves. So spinal nerves are branching off from the spinal cord there. We have a spinal cord at the back, then we see that branch coming off. So when a branch comes off, as a spinal nerve, it will give us two rami. We have an anterior rami and a posterior rami, or simply branches. So posterior rami goes to supply muscles at the back of the trunk, whereas anterior rami supplies muscles in the anterior compartment of the trunk. So if you have muscles at the back there, they are being supplied by the posterior rami. Now we see that when the intercostal nerve comes off from the anterior rami, it runs underneath the ribs, and we're saying it is part of the neurovascular bundle. Then in the lateral aspect of the chest, we see this nerve giving off branches. So it will give us a lateral cutaneous branch. So this branch goes to the skin. It's a sensory branch. Then a motor branch continues. Motor branch will eventually give us an anterior cutaneous branch, another branch supplying the skin. So we have two branches. One branch is supplying the lateral aspect of the chest, that is the skin. Another branch supplying the anterior aspect of the chest on the skin. Then what is running underneath the ribs is the motor branch, controlling all the muscles there, the external intercostal muscle, internal intercostal muscle, and innermost intercostal muscles. So that is all. What I forgot to mention is that the lateral branch will have, the lateral cutaneous branch will have its anterior branch and a posterior branch. Similarly, the anterior cutaneous branch will give us a medial branch and a lateral branch. So the intercostal nerve, apart from controlling the muscles there, is also giving sensory function to the skin. So you find that if there's damage here, for example, there will be loss of function of these muscles and also loss of skin sensation. But if the damage is at this point, the sensory function will remain, but the motor function will be knocked out. Okay. Then when it comes to arteries and veins, so here we have now the whole neurovascular bundle. So veins accompany arteries. So the arteries that supply the intercostal space or arise from the aorta. So that is the thoracic aorta there. Another one comes from a branch of the subclavian vein, known as the internal thoracic artery here. So from the posterior aspect, a branch of the aorta, which we call the segmental arteries, or segmental arteries will form the posterior intercostal artery. Okay. Then the anterior intercostal artery are arising from the internal thoracic artery. So the two branches merge, they form an anastomosis here. You see that this branch is coming from there, from the aorta. This one, internal thoracic artery, is running besides the sternum. So beside the sternum, there is artery and vein. That is a branch of the subclavian artery. The subclavian artery is the artery that supplies blood supply to the upper arms. It sends off a branch into the chest. So the two create an anastomosis there. Then they have their accompanying veins. So these three structures, collectively known as neurovascular bundle: intercostal vein, intercostal artery, and intercostal nerve. So we are saying every time you are performing procedures to do with the chest, for example, thoracocentesis, pericardiocentesis. When inserting the needle through the intercostal space, avoid inserting the needle just below the rib. Always insert the needle above the rib, because these vessels run in the undersurface of the rib. So the needle during thoracocentesis, or indeed underwater seal drainage, has to be inserted above the rib, here and there, so that we avoid damaging, especially the nerve and artery, because artery never stops bleeding. Nerves undergo auto suture. When a vein is punctured, it collapses, and therefore blood, oozing stops. But artery doesn't do that; it remains bleeding for a longer period of time. Worse, if there is damage to the nerve, all the muscles will be paralyzed. Then within the thoracic cage, we have also lymphatic vessels. Okay, remember the cisterna chyli. Cisterna chyli is found in the abdomen there, and then enters into the thoracic cavity together with the aorta. So the opening where the aorta is found, because aorta runs from the chest into the abdomen, is also where the lymphatic from the abdomen are climbing up into the thoracic cavity. So we have two major vessels of the lymphatics in the chest. We have the right thoracic duct and the main thoracic duct, or simply thoracic duct. So thoracic duct is on the left, this one here. Then the right thoracic duct is there, right thoracic duct. Now, the right thoracic duct drains only a small portion of the body. It drains the right side of the head, right side of the neck, and the right side of the arm, and the right side of the chest. Then the remainder of the body, that is the left face, left neck, left arm, left chest, the entire abdomen, the entire lower part of the body is drained by the main thoracic duct, or simply the thoracic duct, which is here. So the thoracic duct in the chest runs on the right side until it reaches at the angle of Louis here, the steno angle of Louis. I explained the steno angle of Louis in the first presentation. At the level of the steno angle of Louis, the thoracic duct shifts from the right side of the chest to the left to go and join the subclavian vein. So all lymphatic vessels are connected to either the right thoracic duct or the main thoracic duct. All lymphatic vessels and lymphatic nodules or lymph nodes, lymphatic ducts and all lymph nodes are connected to this circulatory system by connecting themselves to the thoracic duct, which drains the majority of the body, or the right thoracic duct, which drains only a smaller portion of the body. The two vessels join the left and right subclavian veins. These are veins that are connected to the superior vena cava. Okay. So this is what I was explaining, that when you're trying to remove maybe air, blood, or pus in the pleural cavity via NG, underwater seal drainage, or thoracocentesis, ensure that the needle is passing through above the rib and not below, to avoid damaging to the neurovascular bundles. Let's look at movement of the rib cage. So the rib cage is divided into upper and lower rib cage. So upper rib cage, that is rib 1 to 6, lower rib cage, rib 7 to 12. Sometimes some books may add rib 1 to 7 as upper and then rib 8 as lower. There's some bit of variation here and there. So the movement of the upper rib cage is said to be pump handle movement. So what happens is, during inspiration, when you're taking in air in the lungs, the upper rib cage moves like a pump here, from the bottom up and anterior-wise. So it moves superior and anterior. It pushes the sternum in front and lifts the rib cage. So that is pump handle, like a monopump. Then the lower rib cage is like a bucket handle. The handle is here. If you want to lift the handle, it has to move out, that is lateral, and up. So it is lateral and superior, whereas the upper rib cage is anterior and superior. So that's how the rib cage moves during inspiration. Then here we have muscles of inspiration on one hand and muscles of expiration on the other. The main muscles of inspiration is internal intercostal muscles and diaphragm. Of the two, the diaphragm is a major muscle of respiration, in and out. It's the diaphragm. So when you're breathing in and out, you're using external intercostal muscles and the diaphragm. Then when you're breathing out, mainly this is a passive movement. When the lungs recoil or go back to their original state, air is pushed out. So you don't need to use any muscles there. But during active breathing, then intercostal muscles, internal intercostal muscles are used. In addition to that, abdominal muscles are also used. That is rectus abdominis muscles. We have serratus anterior muscle. We have external oblique abdominis muscle. We also have internal oblique abdominis muscle and transversalis abdominis muscles. But remember to say breathing out is passive. It's rare that we engage muscles during that activity. Okay, next now we'll look at the divisions of the respiratory system. So we have two systems that we use to divide the respiratory system. We have the anatomical division. We also have the physiological division. So the first one we'll look at is the physiological division, looking at function. So if you're dividing the respiratory system using physiology or function, we are going to divide it as following. We have conduction zone and respiratory zone. So the conduction zone involves all structures from the nose all the way down up to the respiratory, up to the terminal bronchioles, sorry, up to the terminal bronchioles. So that is nose, pharynx, larynx, trachea, bronchus, bronchioles. Now there are two types of bronchioles in the lungs. We have respiratory bronchioles and terminal bronchioles. So terminal bronchioles are further from the alveoli, whereas respiratory bronchioles are closer to the alveoli. So at this stage where it is blue, those are terminal bronchioles, and these are part of the conduction zone. So conduction zone simply channels air towards the alveoli. Then after that, the lower part, the lowest part is now called the respiratory zone. This is where gaseous exchange takes place. So it involves the following structures: the respiratory bronchioles, alveolar duct, and the alveolar sac themselves. Three structures: respiratory bronchioles, alveolar duct, and alveolar sac. Okay, so that is a point of division. So the air that is in the conduction zone is not involved in gaseous exchange, except for the air that is involved, that is found in the respiratory zone, is the one that is involved in gaseous exchange. Let's look at anatomical division. Anatomical division, okay. Okay. So this is a larynx there, okay. Now, when you're looking at anatomical division, we divide the respiratory system into two parts. We divide it into lower and upper respiratory tract. So this is the commonest classification that is used. We use the anatomical division based on structures. So the upper respiratory tract involves the nose, the pharynx, and the superior part or the upper part of the larynx. The lower half of the larynx belongs to the lower respiratory tract. So lower respiratory tract will involve the following: the lower part of the larynx, the trachea, the bronchus, the bronchioles, the alveolar ducts, and the alveolus themselves. So if you cut open the larynx, or what we call the voice box, you're going to find the vocal cords there. So the vocal cords lie midway in the larynx. So if you divide the larynx into half, the line that you're using to cut the larynx in half, that's where you're going to find the vocal cords. So above the vocal cords, going up to the nose, is the upper respiratory tract. Below the vocal cords, going down to the alveoli, is what we call the lower respiratory tract. And we see that there are infections that affect the upper and those that affect the lower respiratory tract. Good morning, how are you? All right, thank you. Okay, now we look at the trachea. So the trachea, we're saying this is a windpipe, as some books would call it, but in anatomy, we restrict ourselves to trachea because those are layman's terms. So the trachea is said to measure about 10 to 15, to 10 to 11, up to 15 centimeters long, depending on your height. Now, I'm very skeptical using these measurements because the length of the trachea depends on your height, the length of your neck, to be specific. So that's why we use these fixed positions. So the trachea will be found between these two positions. Superiorly, the trachea originates at cervical vertebrae number 6. In the neck, we have 7 vertebral bones. In the chest, we have 12 vertebral bones. So in the neck, it begins at the 6th vertebral bone, then ends at the 5th thoracic vertebra bone in the chest. So this is a better way of measuring the trachea. So whether you're tall or short, it will still be found in these two locations or between these two ranges. So the trachea is beginning just inferior to the larynx. This is the cricoid cartilage of the larynx. So the trachea begins here, then ends here at this point called carina. This is a carina where the trachea ends. From the carina, the trachea divides into left and right primary bronchus, or what we call the many bronchus. So that is the trachea. In addition to that, the trachea is just a muscular tube. Apart from that, the trachea is surrounded by C-shaped cartilaginous rings. These are hyaline cartilage rings, okay? Then in addition, inside there, it has mucosa and submucosa. Now, the kind of mucosa found in the trachea is pseudostratified columnar epithelium with cilia. These cells have a lot of cilia, and the cilia helps to move the mucus. Because this epithelium has also goblet cells. So those goblet cells secrete mucus. The mucus traps the dust together with the microorganisms. Then cilia moves that mucus together with the trapped particles towards the pharynx. So that is all about the trachea. Now, since these hyaline cartilage rings are not complete, at the back there, they are held together by a smooth muscle called trachealis muscle. So this is trachealis muscle we are seeing here. Then posterior to the muscle will be the esophagus. So you see that the boundary between the esophagus and the trachea is just muscle here. So if by any chance, during intubation, you're trying to do endotracheal intubation, you force the tube so much, you find that this thin muscle can be punctured, and therefore air will be entering in the esophagus, or vice versa, where food will be going into the trachea during swallowing, because it's just a thin layer of muscle. Okay, now let's look at the lungs. Okay. Now, I'll talk about the bronchus and the bronchioles later on, but let's look at the lungs first. So lungs, we have two lungs, left and right lung. It's easy to know which one is the left lung, which one is the right lung by simply comparing the number of lobes it has. Okay. Just hold on a minute.